Hello everyone, this is Dr. Singaram. Welcome to this session about NEET-PG recall session in the subject of pediatrics. So before we start the discussion, I want to give my overview about the type of question asked in this NEET-PG exam. It was a very standard paper having the usual expected question as well as some new questions also, and also some clinical scenarios where you have to apply what you have read to that particular clinical scenario. And there were of course one image based question also, like a spotter type of question, which I'll be discussing. And before I start the session, these are all the recall questions which are given by the students who have actually attended the exam. So there can be variations which can be possible when compared to the actual question in the exam. So depending on the wordings, the final answer may change. So I am going to make the discussion based on the information I have got from the students who have attended the exam. So with that introduction, let us go into the questions. The question number 1, clinical scenario question. An unusually tall 14-year-old boy with extremely long limbs came to ophthalmologist with the complaints of diminution of vision. On examination, there was bilateral subluxation of lens or ectopia lentis was noted. Which of the following defect is found in this condition? Before we go to the name of the genes, let us have a look at the condition we are dealing with. The important clues which are given in the question are tall stature with extremely long limbs. That is number 1. Number 2 is some problem in the vision characterized by subluxation or ectopia lentis which is noted, right? And this is a male child. So with this combination of features, what is your clinical diagnosis going to be? It's a clear case of Marfan syndrome. There is no doubt about the diagnosis. It's a case of Marfan syndrome. We all know it's an inherited disorder. What is the genetic basis of this condition? It's an autosomal dominant disorder characterized by mutation in a gene called FBN1 gene. This is the name of that gene. And this gene codes for which protein? Yes, fibrilin protein, which is affected in this condition of Marfan syndrome. And can you tell me which chromosome is this gene located? It's in chromosome number 15, long arm of chromosome 15. Okay, if you want to know the full version, it is chromosome 15q 21.1. This is the name, this is a location of the abnormal gene in this particular condition. Now, when we talk about the clinical features of this condition, there are 3 core features or 3 main features that we need to know about. Number 1 is tall stature. This was given in the question. Now, if you see, this is a clinical picture of a patient with Marfan syndrome where you can see tall stature very strikingly noted, and the another striking point is this. What is that? It is unusually long limbs, right? That is what you can note very clearly. It is unusually long limbs. That is why in these children, if you ask them to stretch the hand or you measure the arm span, it will be too much more compared to the height. So it is a long limbs which is characteristic of this condition, number 1. Number 2, if you look at the upper segment, lower segment ratio, tell me what would be the ratio. Remember, lower segment is the one which is contributed by the limbs. Here the limbs are unusually long, so the ratio becomes decreased compared to their age. This is called disproportionate type of tall stature. This is called disproportionate type of tall stature because long limbs is the central feature of this condition. Then when you look at the fingers, what is the characteristic finding in the fingers? It's long slender fingers. What is the name of that? It's called arachnodactyly. Arachnodactyly. So one of the defining features of this condition is the stature, tall stature along with the long limbs. What was the second characteristic clinical feature of this condition, which was again given in the question? Yes, subluxation of the lens or the ectopia lentis. This is something very important. And recollect and tell me, where is the dislocation or subluxation? Is it superior or inferior? Yes, it is superior lens subluxation, superior. That is what you need to know about. Number 2. Number 3 is a feature which is not manifesting in children or adolescents, meaning it's an adult onset feature. Something related to the cardiovascular system. What is that? Yes, aortic root dilatation. Aortic root dilatation. And it can cause further problems like aneurysms also. But it is not given in the question because it's an adolescent we are talking about. Usually in the adult age group, this cardiovascular manifestation becomes very prominent. So based on all these discussions, the clear answer for our question is the clinical diagnosis is Marfan syndrome. So the defect is noted in fibrillin 1 gene. That is the option C, which will be the answer for this. FBN1 is a short form of this fibrillin gene, right? Okay. So that's about the first question which is completed. Moving on to the second question. It's a pretty straightforward question. A 6-year-old boy is brought to the emergency department with the complaints of fever and seizure. Some of the students could recall that it was a generalized tonic-clonic seizure, GTCS, generalized tonic-clonic seizure. What is the most appropriate immediate treatment for the control of seizures in this child? That means they are asking about what is the first anti-epileptic to be used for this child. What is our clinical diagnosis in a 6-year-old boy with a fever and generalized tonic-clonic seizure? It is the most common cause of seizure in young children. What is that? Yes, febrile seizures is our diagnosis. Very straightforward one. Febrile seizures is our clinical diagnosis. All 4 are anti-epileptics only, namely diazepam, fosphenytoin, valproate and ethoxyximide. What is going to be the first drug in the management? Let's do a quick recap. In febrile seizures, the first anti-epileptic is always belonging to which group? Yes, it is benzodiazepines. Don't forget that. It is benzodiazepine. And ideally, what is the route of this benzodiazepine to be given? It is intravenous route. Okay, you can use diazepam, lorazepam, midazolam, but the preferred route is the IV benzodiazepine. As an alternative, if you are not able to secure an IV line, the other forms of administration of benzodiazepine would include parectal administration of which drug? Parectal administration of, yes, diazepam, or one more alternative would be intranasal administration of which drug? Yes, midazolam. So always keep in mind the first anti-epileptic for management of febrile seizures is intravenously administered benzodiazepine. You can go for alternates if IV route is not available. Then suppose the seizure is not getting control with benzodiazepine, the second line could be 3 medication. Any one of the 3 can be used. What are the second line medication? Yes, phenytoin. Now we are using fosphenytoin. Any other drug, second line medication? Valproate. And one more would be levetiracetam. Any of these 3 can be used as a second line medication. Now, only one more question I wanted to ask. Suppose you have a baby with seizure or neonatal seizures. What would be the first anti-epileptic you use to control the neonatal seizures? Is it the same benzodiazepine? No. For neonatal seizure, the first anti-epileptic to be used is phenobarbital. This is also a previously asked question, phenobarbital. So, this is a pretty straightforward question. And the answer for this question is going to be diazepam, which is the benzodiazepine among the given options. So, option A is the answer for this question. Moving on to the next question. This is an entirely new question. Okay, right? It's a fact-based question. So, we need to know the facts before we answer this question. This question is about a mother feeding her 7-month-old newborn, 7-month-old baby with the thick homemade cereal as supplementary feeds, right? We all know that after 6 months, complementary feeds will be started on top of breastfeeding. Okay. What is the volume and frequency of these feeds which should be most appropriate for this baby in a period of 24 hours? That means per day how much you will feed based on the guidelines given by infant and young child feeding, IYCF guidelines. Is it half to 1 katori 4 times a day, half to 1 katori 5 times a day, half to 1 katori 6 times a day, half to 1 katori 3 times a day? Now, I think all the options are uniformly giving half to 1 katori, so there is no confusion with that. It is how many times per day which will decide your answers. So, as I told you, it is purely facts. So, I will just take you through the key facts regarding complementary feeding. First and foremost thing, how should be the consistency of the complementary feeding? Is it going to be fully liquid, fully solid or semi-solid? Yes, it is semi-solid. Or in other words, you can also remember like thick liquid-like consistency, right? The better word to use is semi-solid consistency. That is number one. Number two, how much to feed in every serving? It depends on the age of the child. If the child is 6 months to 1 year, it is half to 1 katori every time you have to feed it. If the child is more than 1 year of age, it is 1 to 1.5 katori feeds to be given every time. So this is how much to feed. And how frequently, how often to feed per day? Again depends on the age of the child only. If the child is 6 months to 1 year, it is 3 times per day you have to feed. Remember, this is in addition to breastfeeding, right? Only complementary feeding is 3 times per day. Now, if it is after 1 year, it is 5 times per day. 5 times per day. So, in our question, what was the age of the child? It was a 7-month-old child. So, obviously, it is half to 1 katori per serving. And how many times per day? 3 times per day. And option D will be the clear answer for this particular question. So, that's about this particular question. Moving on to the next one, it's an image-based spotter type of question. A newborn presents with a deformity in all 4 limbs and there was no index finger in the right hand. I'm not sure if it was the same wording, but some pictures what I have put up in the screen were actually given in the question. What is the likely diagnosis? Is it an amniotic band syndrome? CTV, that is congenital talipes equinovarus? Is it cerebral palsy? Arthrogryposis multiplex congenital. Now, we need to identify from the picture. Can you see that in this picture, this area, which I am marking like this, what are you able to see? You are able to see something like a constriction ring, okay, something like a constriction, something like a narrowing in that area, causing some sort of partition in that limb actually. This is what we call it as constriction ring appearance. Constriction ring appearance in the limbs, number one. Number two, you can see very obvious abnormalities in the fingers also. Can you see that? Here also some sort of constriction ring is noted. Here the distal phalanges of the fingers are not developed at all. So these are all very suggestive of something called amniotic band syndrome. Amniotic band syndrome. It's a spotter type of question. So let us just try to understand what is this amniotic band syndrome and then again have a correlation in this question. See, these are the pictures. Now, just try to understand what is the meaning of this amniotic band syndrome. See, it's a condition, something like what I've given in the picture. All these are fibrous strands. Okay, understand that. All these are fibrous strands which are coming from the amniotic sac and entering into the fetal area, where what they are going to do, they are going to entangle the fetal parts, where they are going to entangle the fetal parts. Usually the limb areas are affected. Can you see in this picture also that fibrous band is encircling the lower limbs, causing something like a constriction in this area. Can you understand that? Constriction in the area. This is what I was talking about as constriction ring appearance noted in the limbs. Now this constriction limbs can lead on to further consequences also. Number one, it can be purely causing a cosmetic problem. Think about this, okay? Just like a demarcation noted in that area, nothing more. It can be only causing like a cosmetic problem. Sometimes it can impair the venous return or the lymphatic return from the limbs, leading on to edema, and this edema would be in this area, okay, right? In this area the edema can be noted. That means distal to the obstruction, edema can be noted due to impairment of the venous or the lymphatic drainage in that particular limb. That can be possible. Sometimes what can happen, so much of blood flow can be decreased or no development of the toes or the finger can happen, even leading on to amputation of the fingers of the or the toes. Amputation of the fingers or toes can happen. Okay, all these are consequences of the constriction in that particular area. Now, I told you limbs are the commonly affected area. Other areas also can be affected. Sometimes the face can be affected, ears can be affected. So other external abnormalities also can be possible. Now, let me put one question in front of you. If I have some external abnormalities in a baby, what is the other set of conditions I may think about? I may think about genetic syndromes, correct? Genetic syndromes. They are also characterized by this dysmorphic facial appearance or external abnormalities, right? So now my question is, if I have a baby with some external abnormalities, how will I differentiate genetic syndrome from amniotic band syndrome? Okay, there are three things which will help to differentiate. Number one, limb defects can be noted, but the limb defects in genetic syndromes are usually bilateral, but here it is not bilateral. It may be only unilateral. Number two, in genetic syndrome, the limb defects are same on both sides of the limbs, okay, right side and left side. That means it usually symmetric abnormalities which is noted. But in case of amniotic band syndrome, the limb defects are asymmetric in appearance. That means only right side may be affected or only left side may be affected, not both the sides may be affected equally, right? That is the meaning of this. So limb defects in amniotic band syndrome are not bilateral and also they are asymmetric, not symmetrical. That's what you need to remember, right? That is number one. Number two, will there be a family history in amniotic band syndrome? Family history is usually absent. Please understand, amniotic band syndrome is a problem occurring in utero. In medical terminology, we call it as in utero mechanical disruption. That means what? The fibrous bands from the amniotic sac are causing some constriction in the fetal parts. It's something like a mechanical problem. It is not an inherited problem. So that is why family history is absent in amniotic band syndrome, whereas in genetic syndrome, many times family history is of a similar condition is usually present. That is something to be kept in mind. Third, you tell me, what will be the karyotyping? Absolutely normal in amniotic band syndrome, whereas karyotyping may be abnormal in genetic syndrome, right? So this is how you differentiate amniotic band syndrome from genetic syndrome. So based on all our discussion, the clear answer for this particular question is option A, which is amniotic band syndrome. It's more of a spotter type of question. So please keep that in mind. Okay. So moving on to the next question. It was a question about a baby born to HIV positive mother. A primigravida mother was diagnosed as HIV positive at 34 weeks of gestation and ART was initiated. Viral load of the mother was found to be 1200 copies per ml. The baby was delivered at term weighing 2.5 kg through vaginal delivery and the baby was healthy at the time of birth. What should be the next step in the management if the mother has decided to breastfeed the baby? Please remember that in a mother who is HIV positive, the feeding depends on the socioeconomic status of the mother after considering the family status, right? And here the mother has decided to breastfeed the baby. So we need to keep this point in mind and then discuss further. Will you give a single dose nevirapine and then advise breastfeeding? Will you start nevirapine prophylaxis for 6 weeks and along with breastfeeding? Or will you give nevirapine plus zidovudine for 12 weeks along with breastfeeding? Or breastfeeding and formula feeds to be given together with no prophylaxis? First and foremost thing, you tell me whether this baby requires prophylaxis or not. Definitely, if breastfeeding is started, prophylaxis is always required. So with that understanding itself, the last option is very wrong. Okay, it is very wrong. Now look at the first option. When you have decided on the prophylaxis, will you give only single dose of nevirapine? No. Nevirapine is prophylaxis, but it should be given for few weeks, not as a single dose. So that option is also wrong in this question. So we are left with second and third option. Before we decide our final answer, you have to know something called risk stratification in babies born to HIV positive mother, because this will help us to decide what type of prophylaxis we are going to give for this baby. Number one is low risk and number two is high risk. What is called as a low risk baby? Low risk baby is if the mother is on ART. If the mother is on ART throughout the pregnancy, then the baby becomes low risk. Second thing is you have to check the viral load of the mother. Very important, viral load of the mother. And if the viral load is suppressed, what is the meaning of suppressed viral load? Less than 1000 copies per ml, and this viral load should be detected after 32 weeks of gestation. Okay, so after 32 weeks of gestation, if the mother has suppressed the viral load, then also baby becomes low risk. This is the criteria for a low risk baby. On the other hand, high risk baby is the opposite. That means the mother is not on antiretroviral treatment, number one. Number two, if the viral load in the mother is increased. What is the meaning of increase? More than 1000 copies per ml. Or if the mother's viral load is unknown, it was not even tested, mother's viral load is unknown, then baby becomes high risk. And third is, if the mother was detected to have HIV positivity within 6 weeks of delivery, that means she is recently diagnosed to have HIV, then also baby becomes high risk. Now with this information, if I take you back to the question, tell me, what is this baby falling under, high risk or low risk? Definitely it is high risk, because you can see the viral load of the mother is more than 1000 copies per ml. So this baby is a high risk baby. That part is clear. Now let's decide what should be the prophylaxis if the baby is high risk. Okay, if it is high risk, in view of that increased risk status, we need to give dual prophylaxis. Dual means two drugs should be started. What are the two drugs? It is nevirapine plus zidovudin should be started for 12 weeks. It should be given along with the breastfeeds, but for the duration of 12 weeks. Suppose it is only a low risk baby, then it's a single drug prophylaxis. What is a single drug for prophylaxis? Of course, it is nevirapine should be given for how many weeks? Yes, 6 weeks. Okay, so taking you back to the question, it is very clear that our baby is at high risk. So two drug prophylaxis for 12 weeks should be given. So option C will be the answer for this particular question. Okay, right. Moving on, a neonate was screened and was found to have congenital hypothyroidism. T3, T4 levels were decreased and there was no radioactive tracer uptake, but thyroid gland was normal on ultrasound. What is the most likely diagnosis? This is a question purely based on evaluation of a baby with congenital hypothyroidism, but in terms of radiological evaluation. We all know that the radiological evaluation is of two parts. Number one is the thyroid scanning or the radioiodine uptake scan or the tracer scan, like that. Second thing is the ultrasound of the thyroid. And based on this only, this question is going to be answered. Okay, so let us do it in a stepwise manner. First is the thyroid scan. We can have three types of reports based on the thyroid scan. Number one is ectopic uptake. It is ectopic uptake. Number two, no uptake. Number two is no uptake. And number three is increased uptake. Okay. Now let us see what all would be the possibilities. Straightforward one. Ectopic uptake means there is a ectopic location of the thyroid gland. For example, in the base of the tongue it may be present, or lingual thyroid, like that. So it is ectopic thyroid. That would be the diagnosis. Next, if it is no uptake, there are different possibilities. Our further evaluation will be based on the ultrasound of the thyroid, USG. If the ultrasound doesn't able to visualize the gland, or gland is not visualized, then tell me, it's a very straightforward diagnosis. What is that? Thyroid gland is not even developed at all. What do you call that? Thyroid agenesis. Okay, thyroid agenesis, not even developed. Suppose on ultrasound, the thyroid gland is visualized or seen. Now you tell me what could be the possibilities. It could be due to maternal antibodies. We call it blocking antibodies or maternal antibodies. Or it could be due to iodine uptake defect. Okay, right? Iodine uptake defect. Okay, some sort of defects related to uptake of the iodine by the thyroid gland. Okay, that could be possible. If it is increased uptake, what is the condition going to be? Yes, it's a condition of hormone production problem. What do you call that? You call it as dysharmonogenesis. You call it as dysharmonogenesis. Yes. Now, if you go back to the question, the question was saying very clearly the radioactive tracer uptake was absent. There is no radioactive iodine uptake, but thyroid gland was normally noted on ultrasound. So, what is going to be the possibility? No uptake on the thyroid scan, and it's a normally visualized thyroid on USG. What is going to be the possibility? It is either maternal antibodies or iodine uptake defect. So, what is the clear answer for our question? It is defect in the iodine transport or something like iodine uptake also. Okay, right? Iodine uptake or iodine transport, both are equivalent terms only. So, option B will be the answer for this particular question. Because if you see the other options, thyroid agenesis, there is ultrasound itself will not be able to visualize the gland. Dysharmonogenesis, there will be increased radioiodine uptake, right? So, all those things are ruled out. Clear option, clear answer for this question is option B only, defect in the iodine transport. So, with that was the completion of the discussion of questions in NEET-PG asked in the subject of pediatrics. Thank you.